objectives of this assessment, right? So I showed you this form, and if you look on this form, I don't know if you looked at it really carefully, but on this form is a wound progress, and I don't remember if I posted this, so I will check it. Can we see it better now, and then I'll just scroll over? Okay. So first is a pictorial representation of where the wound is. Second would be the date. Was this present on admission? The reason why you want to check that is because of etiology. And if it came from a facility or from home with a wound already, that has to deal with liability claims and payment issues. Okay. And then we would write the location. The stage being here is only appropriate for pressure injuries, aka pressure ulcers. The new term is pressure injuries, not pressure ulcerations, or acute eye ulcers. You'll hear it. Right? All those are old school. Okay. The wound type you can't answer yet because you haven't had the etiology yet, but that's what you would put there. And then there's your size, length, width, the color, your percent granulation tissue, your drainage, your odor, is there any cavity. Now, what I don't like about this is it doesn't have anything else besides tunneling. Undermines is not listed, is it? It might say it won't stop. Hold on. Oh, yeah, it does. So here's the general initial identification. So this form works with initial identification, and this would be something that was, sorry, let me back up here. Let me do the big overall. Okay. So each one of these boxes identifies with one of these, typically the initial identification site, and then you can be putting in additional details here. So this starts here and then it continues on. Some people use this form with initial identification sites only being ones that they saw on admission, and then they use these for the regular assessment. So there's no really standardized scope. When I used a form like this, we had our own version of it, and so it would identify the, this was always used for whatever I did. It was at what the nurses did. The nurses had a different variation of this, and you had to identify things at addition so you could see what it was at. And they specifically did not have to identify that type or anything else, because where you run up into problems in the wound care world is if someone comes in and says that one person has a stage 4 pressure injury, the next one says it's a stage 2, the next one says it's a surgical wound, and the next one says it's an arterial. 4 different etiologies for the same wound. So they're trying to get away from that. Okay. But overall, all the things we learned about last week are on this form. That's the objectives are. So what does the wound look like? What tissue's there? What's exposed in it? What's the cavity? What's the sinus? What's the depth? What's the wound margin, surrounding tissue? Anything else that's going on with the patient? So this is just specific to the wound. Now your other systems review is not on this form. So the systems review would be in your regular documentation. Why do we care? Well, from all the stuff that we gathered last week, then we have to make wound goals and documentation. We have to document what we saw. And I didn't get a chance to go over that last week. So, for wound goals, how do you make goals for wounds? Well, first of all, you have to know your end goal. Is the end goal going to be delayed primary closure versus secondary? What does that mean? Remember that from last week? What's delayed primary closure? It was induced by, it was open surgically, they left it open, they're going to leave it open for a defined amount of time, and then they're going to take it back to the OR to close it, right? What's secondary closure? It's going to be left open, and we just want to facilitate it from closing to closing. Okay? The other type that's there is primary, but I left primary off because 99% of the time you're not going to see primary. They do have primary wound interventions. Advanced practice, I did not know. And there's a lot of new technologies that I don't know enough about. They've got special incisions to facilitate complete closure and fluid removal without the incision, which is pretty cool, but I don't know how it works. So I'm not teaching you yet because I have to go through and continue to learn how it works. So, first of all, know your end goal. So, is this going to be secondary closure or delayed primary closure? Why do I care about that distinction? Timing, what else? am I gonna try to close the wound? Am I gonna try to close it a little bit? Am I gonna try to close it a lot of it? Am I gonna try to make sure that there's no swelling or edema or infection? And also, when you're looking at delayed primary closure, your wound care time frame is 2 to 4 weeks. That's your end goal. The other ones, for secondary closure, depend on the etiology of the wound. So a surgical wound may close in a month, versus a diabetic wound may close in 6 months. An arterial wound may close in 9 months. So what you're going to do is when you get to the etiology, you'll have an idea of how long these things typically heal, and that then becomes your end goal for the goal, your end range for the goal. So it's not like, oh, in 3 to 5 days you gotta get this, in 6 to 7 days you gotta get this. If you're that good, you need to write a book and go get an award. Okay, because I've never seen it, except for little people. Right? The other thing is you want to be able to identify the phase of healing you're currently in, right, from your effective measurements, so that you know where you have to go. Now, if I'm giving them a secondary closure, I want them to go through, do I want them to go through all 3 phases of healing? Inflammation, proliferation, and remodeling? Yeah. I want them to get to the remodeling phase. For delayed primary closure, where's my end goal with that, with the phase of healing? I want to get out of inflammation into fluid proliferation. I want to fill the deficit. I want to make sure there's no infection. I want to make sure there's no edema. I want to make sure that the fluid is being controlled well. Okay. So that way, when the surgeons go to take their surgical utensils and approximate the wound, physically pull it closer, so they're going to get a really good seal, and they're not going to get any abscesses or cavities, because the depth is flush with the wound edge. Ideally, you want the depth of the wound to be rid of the edges or be a little bit smaller. Now, sometimes your goal with the surgeons is not to fill a deficit for delayed primary. Sometimes it is to make it nice and red, and then they're going to go get synthetic acrylic through the skin to fill the hole because the hole's too big. So sometimes they're going to use a skin substitute product, which we'll have to talk about. There's, and it's a lot of the same stuff we see used for burn patients. So there's all kinds of different names and fancy, cool things. Did anyone read After the Fire? Yeah, in that book they talk about some of the different closures. Do you remember them talking about the bilaminar shark skin that they used in there? I don't know if they said it was shark skin, but that's what it was. And they filled most of his holes with this, and then they go on and wrap on top of that because there was not this much depth taken off. So it's really cool stuff. Okay. So when I'm looking at the primary closure goals, my goals so what are the summary of the goals that I'm looking at? Surgeon says to you, I want to take it back to the OR in 3 weeks. You say, okay, I'll get the wound ready. What does that mean? You're going to get all the granulation tissue there packing, right? Packing granulation tissue. What else? Prevent infection or get rid of any infection. A lot of times the reason why the wound is left open is because it's infected. So you have to eradicate the infection, and then you want to make sure we keep the infection away. Okay. Is it a wound infection or a systemic infection? That's a big distinction. We're going to talk about it because we may have to be putting certain things into the wound to fight the infection, as well as systemically because they have a systemic infection as well. They're treated differently. Okay. What else? So that's 2. Infection and granulation. Yeah. Clean up any other debris, get rid of any other kind of necrotic tissue that exists. Eradicate it. Good. What else?
Make sure the periwound is healthy so they can use suture and close together like the skin.
Good. And how do we make sure that the health is good? So the periwound has to be healthy. How do we make that happen? What do we not want to be there?
Maceration.
Edema, erythema, what else?
Maceration.
Maceration, right? You want nice and tight skin. What else do you say? The edema, yeah. So sometimes with fasciotomies, those are some of the most common ones you'll see that are left open. They can do a 2 or 4 part compartment fasciotomy. Do you know what that means? Depends on how many holes and how many compartments they physically open in the leg. How many compartments are there in your lower leg? Around the muscle band, do you remember? You should have 4 different compartments. Okay? And so if they have to do an anterior, posterior, medial, and lateral decompression procedure, where they go in and they pierce the fascia because the pressure is too big, and if they don't, it's going to cause strangulation for all both muscles. So what they do is they go and they pierce off with fasciotomy, and then they also cut the leg to expose the area to allow all the drainage to come out so they don't lose the leg. Okay. When those happen, you have ridiculous amounts of swelling. Right? With that kind of swelling, you're typically not wrapping it with compression devices, because the compression device you put on is going to reinduce the fasciotomy compartment syndrome. Got it? So we use other modalities, which you'll learn about, to reduce, decompress the fluid in the area. Okay? So no edema, good purity wound, healthy granulation tissue. Okay? No necrosis, no infection. The other thing that we want to do is we want to try to get the depth as the least amount possible. You want to try to fill in that deficit as much. So if there is undermining, if there is tunneling, sinus tracts, you want to try to fill the tunnel and the sinus tract and then fill the depth. You don't want the depth to come up with a hole still there, because what will happen is it'll trap whatever anaerobes are there, or aerobic bacteria. It will circulate, sit, be happy, replicate, invade, and they will get a huge infection. So that's not a good thing. Okay? For secondary closure, our goals are, they switch. Because now we're looking at whatever the trajectory, the end goal is here to whatever potential diagnosis that you see it is. Okay? On average, if you don't have any literature that guides us, an acute wound should progress through the phases of healing within 1 month, maybe a little bit longer if you're an elderly patient, 2 months. Okay. If you're dealing with a chronic wound, we shift our gears. Chronic wounds typically take 6 months to a year to heal. And then you have to pair on the wound etiology onto that. So sometimes my end goal is not until a year and a half from now. Sometimes my end goal is in a few weeks. It just depends on why is the wound there. Okay, so you can kind of see how they all pair together. All right. So then the next part is, if I'm in an inflammatory phase of the healing, what phase do I want to go to? Proliferation and then remodeling. That's it, right? So I want to get them to go through these phases. Then I want to know what my wound bed, peri-wound, exudate, and drug confession looks like. So what I want to do is I want to get rid of the dead stuff. How do I do that? Well, you're going to learn the breathing techniques. And you're also going to learn what I mean by maintaining little bioburden in just a few short minutes. And then we want to make really nice happy granulation tissue grow. Okay, so generally those are the goals. Then for the drainage, we want a nice happy balance. We like homeostasis. We want it to be just enough to maintain the right temperature and the wound environment for drainage output. Drainage is going to be relative to the size of the hole. If it's a small hole, it's a small amount of drainage. If it's a big hole, you get a big lot of drainage. You get a lot of drainage. Okay? But the type of drainage is also the difference. Okay? If you have purulence or seropurulence, or you have chyme, lymphatic system, now we're into a different realm. Because now we have a lymphatic compartment we have to control. And if you have purulence, do I have an infection that I have? Okay? If an infection does exist, it becomes the top priority. Infection and debridement in the necrotic tissue become the top priority when that does exist. Okay. You'll learn more in sharp debridement. But it trumps everything else. I can't close the wound, I can't do anything until I get rid of the infection. And the necrotic tissue is the infection because it breeds the bacteria on the necrotic tissue. So that becomes the number one priority. Now, if I have maceration, what do I want to do? Well, maceration can make the skin further break down because of the enzymes that are produced in the drainage, as well as the microorganisms are drawn to it like magnet because it's nice, warm, healthy, and I can just breathe as much as I want in that environment. So we want to get rid of it. So typically we're protecting the period with some kind of salve or other things, or barriers, in order order to get rid of an exhalation. Or if it's too little, I get something called desiccation. Do you know what that term means, desiccation? Really, really dried out. Yeah. You ever see anyone fish? Like fish with big minnows? You ever leave a minnow on the pier? You know how hard it is, how crunchy it gets when it's sitting out exposed to the sun? It's the same thing the womb will do. But the womb, when it has too little moisture, the body's smart. And it'll say, you don't have enough here. And it'll start to form slop and dead scabs over it to make an environment so that underneath the scab, it can start to heal. We don't want that. We want happy, open edges. Okay. The other thing is too little or dry bones cause a lot more pain. They also damage granulation tissue, and you're automatically start to see this sloppy environment start to return because the moisture is not okay. So they may not have an infection, they may not have a new problem, but they may have something else going on with now it's causing infection. So when you're looking at wound in progress, if you are assessing wounds on a regular basis, we do an initial eval and we assess it once a week. Okay, we re-measure, we picture, we see how it is. If you notice a sudden decline, all of a sudden it looks way different. All of a sudden it was granulation, and the next day, now it's all necrotic, and there's erythema, and there's all this stuff happening. There's something else going on, right? Versus, I came in this day, and on this day, it's really dried out. That's a big notable change. So you want to pay attention to those things. And not say, oh, well, they forgot to change their bandage. Okay? So why is the warm and moist environment so important? Well, if I just let the body do this on its own without any intervention, what will first happen is you'll get this plaque that forms to kind of seal up. Now, some people say it's the scab, some people say it's just they're composed of different tissues. Okay. So, and I think that was on my assessment last week when I walked you through the scab and vesicle. I put the different, one's composed of sebum and one's composed of orange dead stuff along with others. So when you go back, if you want to know the differential between which one it is, go back to the book club. Okay. What ends up happening in this scheme is that this is the dead tissue that fills the area. All the ones that want to move across will now have to go down, under, and then have to come up to the bottom to get where they want to go. Versus this wound with a nice happy dressing on top, these can just re-move across the way. Okay, so you can see this makes longer heals. That's why we don't want it. We want this up here. Okay. So our goals, if you have depth and wound cavities, we want to get rid of them. Yes?
I have a question. For trauma wounds, sometimes they put an artificial filling in the wound. Is that similar to what you see on the picture?
No.
Like how's that?
No.
No.
You'll learn about it.
Okay.
Not now. Good question. The wound filling stuff is a different ballpark. But if you're talking about facilitating this, are you talking about a facilitating
Yeah,
this?
like I felt like since it's like artificial tissue, it would just be like kind of dead tissue, so it'd be similar to.
Well, is it artificial tissue or is it a
Cool.
wound filling gel?
I don't know
Or
what
is
it
it
is.
the
I just
column and stuff
seen.
that they're inserting into it?
I don't know. I have like very superficial knowledge of what it is.
Okay.
I just say.
Because there's like 4 different ways you can do it. So, you'll learn more as we go through some of those. Okay, so if there's depth, get rid of the depth. Get rid of the depth. How do I get rid of the depth? Well, there's a whole bunch of cool modalities and dressings I'm going to teach you about when we do that. Okay. You also want to make a nice, happy, warm, moist environment that's free of infection. The body will naturally want to play into that. Okay. If there's dead space in the cavity site, get rid of that first before you get rid of all the depth and focus over the spaces. If you have anatomy exposed, particularly tendons, ligaments, fascia, any vessels, nerves, joint capsules, spaces, you've got to protect them if they're ridiculously high infection. Meaning, you make sure that the dressings on and anywhere near them are always moist, that they have very good attention to those things. and you want to try to maintain the moisture, because if it does take a dive, and then those leads to really, really big surgeries. Really, really, really big cardiac changes in the person's function. Okay. So sometimes they will allow granulation tissue formation to go over those structures. Most of the time, the surgeons will take them back and try to cover them with something. So it's not just out there hanging out. But they're high-risk patients when you see those. Okay. Other things, we already said this one. We want to make sure we have a healthy, intact period. Oh, this should be the next bullet. I will. You also want to maintain open corners to promote migration. Meaning you want to get rid of your callus on the edges. You want to get rid of it. Okay? You want to sharply get rid of it. I'll teach you how to do that. And you always want to make sure. And if you can't see the wound edges and they're not exposed, you got to get them exposed. Otherwise, it won't can't move. The wound edges are sealed, they will never close. Then you want to do your best to try to control factors. Well, can I permanently change their oxygen, their blood flow, their nutrition, their comorbidities, the behavioral risk types of speaking? No. So I see some people write goals on, they will, we will control for all contributing factors. Well, I don't know how you're going to do that, objectively measure it, right? So a lot of times it's education, right? A lot of education. So patient can accurately recall all the preventative tips related to optimal movement. So it's kind of like a question and answer. You turn it into an objective measure like that in order to get them to recall the material accurately and without movement. So we really want them to know. Yes, ma'am.
Can you talk more about what you mean by like those loose edges are closed and they want to come together, like if they're sealed?
Yeah, hold on, let me pull up my pictures. Can you pull the lights, please? So this is two diabetic foots that you're looking at. Well, not diabetic, but feet. These are feet with peripheral neuropathies, and etiology is neuropathic. That's correct. So they have ulcerations because of the diabetes. So this is a this person is missing toes from activation, so you're trying to get oriented. This is their left plantar version of the foot. This is a callus that has not yet been derooted. This is a callus coupled with a macerated callus around the third. This is the base of the third metatarsal that's exposed in the base of the knee. So you see all this stuff around the edge? This needs to go because calluses like this. When this lady was open, she had a whole wound that was like this, but you did not see it on the surface. She was taken to the OR and they did it because as soon as I started feeling around, I just did my hand and I said, I'm not doing it for that reason. And I'm glad I did it in that case. This is the diabetic heel right foot plantar aspect, another neuropathic ulceration. Again, can you see the callus that's really thick and wide and how wet it is? So not only, so this edge is exposed, which is good, but over here it's blocked. Does that help? So what I want to do is I want to carve all that out and then get a nice flush image that I can visualize and see. And then I know that my wound cells and my myofibroblasts can migrate and move. So we do like a bevel edge, and I'll teach you how to do this stuff. It's going to be a short degree then. Okay, so educate. Got it? And then you want to do everything you can to try to stimulate healing. What do I mean by that? Wait through differential diagnosis. Because there's all tips and things for you to do. I didn't want to write them all. It's all written in your differential diagnosis.
So when you do have a callus around the wound, like in those pictures, the reason the wound can't heal is just because the collagen cells don't have enough.
That's one of the reasons. But one of the things is that the callus edge is blocked to the wound edge, and that means that the wound edge is preventing myofibroblasts from doing their job, especially if I have a granulation of tissue. Okay. Sometimes there's a lot more. The pictures you saw there, number one, the perfusion was not good. Number two, healthy granulation tissue actually wasn't present in the wound bed. Okay. So there was a lot of other factors we had to fix. The callus was just another thing we had to fix. Okay. All right, so what do I mean? How do you write the goals? So these are specific goal examples. And this is from an old textbook I used to use, but I like it because the CAMS book doesn't give you a lot of good examples of it. So, wound bed will contain at least blank percentage of granulation. That's good, but what I would add to it is, in order to facilitate all of them, the proliferative phase of healing. You want to be able to link your goals to why you're doing it. And in this case, it's not the function of the patient. In this case, is what is the physiology of the healing that you're trying to link it to. Does that mean every goal has to be linked in? No. How do I know about the percentage? Yeah, depends on your initial assessment. And then it depends on the etiology of the goal. And then it depends on how many patients you've seen before, so you have an idea what's actually real. The best estimate to do is always you start bigger than what you think it is. You start longer than what you think it is when you first start until you see enough patients for you to kind of get a good feeling of how long in general do they take. There's also a lot of literature guiding you on how long it should take. And then if it's going to take 6 months, well then you say, well, I need 75% granulation tissue, just divide it. I do things very objectively like that. Like if it's going to take me 6 months and I need 75%, divide 75%, divide by 6, and I know that I want to have a 15% decrease within 4 weeks. Right? You see what I'm saying? So that's kind of how I do it in my head. Is that how you should be doing it? I don't know. It's worked for me for my career. For general time frames of healing, we're going to learn all about those in differential diagnosis. So you can see all the different things I noted in my objective. There's a goal about the depth. There's a goal about the surface area contraction. Okay. There's a goal about granulation tissue, the percent of necrotic tissue. Getting rid of the maceration. We'll be ready for surgical closure. Okay. By evidence of is what should say. We will progress to the proliferative phase of healing as evidenced by epithelialization of granulocytic presence in the wound bed. Okay. Sometimes you don't need a percentage, sometimes you just need to document different hallmarks of healing. Okay. So these are some really good examples that are in here. You also want to make sure that if you're going to write this wound surface area will decrease, be careful of when you write that goal. Because if I have 100% necrotic tissue, I'm not going to see the wound surface area decrease until the necrosis is gone and I'm in the proliferation phase. So if I have 100% necrotic tissue right now, maybe that's a long-term goal, but that sure won't be my short-term goal. Okay? And if I'm going to do a surgical wound prep, then closure is not I don't care if it closes. That's not my goal. Do you see what I mean? So these are just different examples for that. All right, so how do we document that? Well, we know this, right? It isn't written, it didn't happen. You think you're going to be able to remember all these. You think you're going to be able to remember all your patients. I've been practicing for a lot of years. I've been deposed in legal proceedings several times, which is very intimidating. I've been called to be an expert witness, and I continually decline because I hate courtrooms. I don't love them. So, the documentation guidelines that I go by, this is a professional membership that I belong to. It's the WCC credentials behind my name. A lot of the documents I got from them are from the members only section, so you can't get any of this stuff online. So you'll see a lot of stuff that I just post to on Blackboard, and I incorporate into my lectures from. These are their goals. These are the documentation tips. You want to read them thoroughly. Now, what I will say is this thing here, this stage of the pressure ulcer, this no longer is accurate because there was a revised statement in 2000 something, a couple years after this came out. There's new staging guidelines, so you don't follow this part from this. So scratch that out. But all of this staging here, yeah, get rid of it. Because these are no longer the correct guidelines that are there for. You do want to stage them, but these are not the correct definitions. Anyway, you change the way that you do it. So you document the type of wound, the location, document the thickness, is it partial or full thickness wound? Okay, it gives you some guidelines there about, remember partial thickness extends to but not through the dermis. Full thickness is through the dermis. What's their size? What's the depth? What's the cracks? What's the cavities? What's the drainage? What's the odor? What's the appearance of the dead tissue? Okay, what's the percentages? What kind of dead tissue? Do you see any foreign bodies? What that means is, that always comes people. Pieces of glass, pieces of gravel, pieces of leftover dressings, maggots, foreign objects. Yes?
With like a staple or security considered for
It would be if it wasn't there put there surgically. You see what I'm saying? So if they stepped on a box of staples at home, then that would be a foreign body, right? But if they close them surgically, I'm expecting to see some kind of surgical incision. The wound edges, the surrounding wound tissue, any indicators of infection, pain, intervention, conditions, labs, anything that this part 14 pay attention to. This is your assessment. This goes in your assessment part. And this is one of the things everyone forgets on case studies. Okay. Do they have any problems turning, positioning limitations, nutritional limitations, deterioration of a medical status, non-compliance, abnormal labs, infections, continence issues? Okay. If they are in multi-system organ failure, the body doesn't care about the wound. The body cares about the brain and the heart. So they're probably not going to heal. So my job in those cases is to make sure I do everything I can to stop that urine from getting infected. I don't expect closure period to happen. Does that make sense to you? Versus if someone is out of surgery, a stable condition, finally moving, finally having good nutrition, now I'll know that. But if you don't write this in, this is where a lot of losses happen. You also want to document capital treatment plans, modifications, education, and who you talk to in the medical field about the condition to show that interprofessional collaboration. Patient caregiver education, and then making sure that you use anatomical location for the action. Okay. If you want to know, this is a really good website, you can learn more about them. If you want me to show you some of the things that they have, it's pretty cool. They do have a wound care app, by the way, which will help the beginning practitioner identify what on earth they're seeing at bedside. So it's a really cool thing. I don't use it anymore because it's boring. It's boring to me now. But when I first started, it was really cool. And that all that information should be on there. If it's not, let me know. I'm sure I could probably pull it up again. Okay. So here's just an example of something that I wrote a long time ago. And so I leave this in here for you to kind of go over. And you can also kind of evaluate and see what's in there, what's not in there. And you can kind of see the style of my wounded valves. The thing that's not in here is the scans to this patient. And I only have one part of the wound picture. The top part's missing, and I can't find it. And it was a beautiful, beautiful granulation bed that was on top of it. But this was the wound that I was documenting. So you can go through and see some of the do's and don'ts. I don't think I put the plan in for you, so the plan's missing altogether. But the other stuff you can see that's it. And I don't ever think the plan really messes with people, it's usually the same. Okay. That is one document. Let's take, here is something else too. I forgot to talk about the consent for photography. Here is a form. Almost all facilities have a form for consent for photography if it is permissible. you need to make sure that the person is over 18 who signs it, and if not, their parents sign it, if you're gonna use them in photography. Okay? If they wanna take personal cell phone pictures of the wound or of you taking treatments, facility policy trumps. Okay? I never agreed, ever, to allow anyone to videotape or do anything with what I was doing with the patient during the session. Okay? Some docs and other people do. I did not. So you wanna make sure that if you're gonna use this form, that it's okay. And if you're gonna take a video of a session, there's a different media release typically associated with that. There's a lot of legalese, so check policies and procedures. Do you know that there's legal parameters here at GSU about students taking themselves, putting up YouTube videos, social media, taking treatments with patients? No is the answer to all of the above. You can't just take the patient without an active IRB and approval. Like, there's a lot of policies and procedures you've got to follow for those things. So I just wanted to show you what that form is. If you want me to post that, I can certainly post it, but every facility's gonna have their own, but that's just an example. This is what I believe from WCEI. Okay,